19. We have in attendance on the committee, Dr. Neal, our emeritus chair and fortunate board member. We have Dr. McIntyre, our vice chair, and myself, which is a quorum. I'd like to see if it's possible. I know we're working back to back, and I'll just say ahead of time that if we don't have anything next month, the next time we won't call a meeting. I certainly wouldn't ask you guys to be here if I didn't want to review some of these articles. But we don't meet just to meet, we meet to try to work on things. And I'm meeting back to back this time because we had so much. We had almost a year where we almost basically didn't meet. I want to try to do it this way. I'd like to see if we can keep ourselves to about 30 or 40 minutes today, because a lot of you guys have obligations beyond this. And several of these issues kind of dovetail into one each other. So I'm going to use the chairman's prerogative and work on this item number 2 firstly. Amber, can you hear me?
Yes, I can.
Can you want to take a swing at this pitch and set us off with just to briefly touch on these issues that came up last time?
Sure. I think there was a lot of discussion at the last meeting about coming up with some quality measures for the MCOs, and discussion about where that different information is out there, and potential reports. I think one of the questions that wasn't addressed is what is being done currently. Are there any type of quality measures, I guess, that the DMS is currently using to evaluate the MCOs, and if they're actually changing health status in the state, as opposed, what are the measures, I guess, at this point when they file their reports, what is DMS looking at?
Thank you, Amber. Dr. Neal, do you have a lot of institutional recollection on this? Do you want to chime in here, sir?
Well, yes, I'd be glad to. As a matter of fact, we had a meeting. I'm on the quality committee for Aetna, and we met yesterday, and they presented a pretty lengthy report about the things that DMS is really looking at and requiring. And one of the particular things that came up, of course, because of the high rate of diabetes and obesity in Kentucky, particularly in children also, they were looking at, do the templates in our EMRs show that and reflect that we are doing appropriate studies like A1Cs, looking at history of family and all that sort of thing. So they've been given some marching orders, and several of them I don't even remember from yesterday because it's about a 40-page report as usual. But those are some of the things DMS is looking at. Of course, all that kind of pales with COVID, obviously. But I do know that, for example, obesity, which was already a real problem in Kentucky, we had started to make a little inroads in decreasing the incidence of obesity, but with COVID, it's gone back up again. So I could go further, but let me stop right there and let somebody else chime in.
Well, if somebody would like to speak to this issue, I'm very welcome to do it. From the way I think that we would see it is, let me look at it, say, from KMA's point of view. If KMA's, who's a major stakeholder here, because they represent a lot of maybe 10,000 physicians, well, they don't have the resources to put together these quality measures. And, you know, the resources there are with DMS and the MCOs. It's really not with us. And so I don't think we need any more quality measures. I think we need to refine those, and our chief medical officers who are well experienced can help them with that. And I just didn't want to go too far. I didn't want that to leave that an open-ended piece of rope. It's something that we were responsible for, when I really don't see that we had the resources to help you all with that. If somebody would like to speak more to that, I'm welcome to do it, but I'd rather just go on. Is there somebody who would like to chat in about this or have a thought about it?
I'm sorry, this is Angie Parker with Medicaid, and I'm a few minutes late to the show, but I'm the Director of Program Quality and Outcomes. And I'm assuming you're talking about number 2 DMS quality measures for MCOs?
Yes, Angie, thank you for attending.
No problem. And what I missed, and I came in on it, that was it Anthem was talking with the providers about a 40-page document?
No, this was Dr. Neal. I was reporting a meeting from Aetna with their
Aetna. Okay. Well, as a little history, Medicaid has a quality strategy, which is a requirement of CMS, which is a good requirement that we all need to make sure that we're all reviewing quality of care. And this was developed in 2019. So it's already, when it was written, it was probably already too old. It was already needed to be updated. But the one before that was from 2012. So with your conversation with Aetna, I can only assume that part of that is based on the DMS quality strategy, which we are currently looking at and evaluating where we need to target specific quality measures. And to the other position, I forgot, I didn't get your name. Yes, we can't boil the ocean, but we need to make sure that we're focusing on the certain things that we can try to move that needle. And we do need our providers' assistance in that and ensuring that your patients are getting preventive care and doing their follow-ups and those types of things. I think, and not being a part of that Aetna meeting, I think it's more of figuring out a partnership on how to get some of these quality measures accomplished. And I don't know how familiar you are with HEDIS measures, but there are, I don't know, 33 HEDIS measures and they're quality measures. And some of them are, there's like 5 or 6 on diabetes and whether or not they've had, people have gotten their hemoglobin A1C or not. And if it's above 9 or less than 7, and they get a lot of this information. You probably in the spring have somebody from all the MCOs coming to your office to get charged and look at them and see if some of these measures are being met. So with all of that little bit of history with that, I guess my question is, because I did come in a little late to the conversation, what is your concern?
Well, let me try to reiterate. We really don't have a concern here. That's why we're bringing it up. In the last meeting, I think with the commissioner, somehow there was an ethereal belief that somehow, at least my understanding, or from our side, we thought it was left with, we want you to come up with quality measures or designs. And what we're saying is, well, that's not what we're going to do. We don't have that data. That's not our position. We want to make sure that people like you, Angie, and our MCO partners can work on those things. And if you want, you don't need my counsel. Sometimes they say in my business that, a bit of advice that's not welcome is seen as something that's not very good. But I think that what we would say is, if you have less quality measures that are more important, it might be more helpful to you all. It might be helpful to, for example, your primary care workforce, because you can measure too many things and they become overwhelmed. That's just a suggestion. But the only reason we brought it up was saying, listen, this is a hot potato that we can't catch for you, but we're obviously partners with you and we want to work with you. We just don't want you to think that we're going to return something to you when this is kind of what you all do. Does that make sense?
Yes, and I think where the commissioner was coming from is, part of some of the issues that you see day to day, and in those areas and where we could, or the MCOs could assist you in helping improve the quality of care. So
yes, ma'am.
Yes, I think she understands, and we understand that. We don't expect you all to get together necessarily. I mean, obviously, via the TAC, you all could potentially come up with things that you see most quite often, and think that's something that the MCOs and Medicaid could help assist on improving quality of care.
Thank you. Dr. Terrio, you wanted to say something?
Well, I was just going to say one example would be, and it kind of gets to what Dr. Neal was saying with obesity, is the diabetes prevention programs. And when you look over the last several decades at the America Health ratings, Kentucky has basically stayed the same. We're not doing great on, smoking and diabetes and all of those things. But one thing that's come out is that they've done studies, and if a physician suggests, maybe not the first time or the second time, but maybe the third time, that a patient attend a diabetes prevention program, that seems to be the key to get the patient to do that. And all that is people actually diabetes and you talk to them about it, and then they get nutrition and exercise counseling in an organized manner over about a 4-month or 6-month period. But and so I think that's, some of the studies that are coming out, it does show that the physician referrals make a really big difference. And I do know, that it's hard. Sometimes you suggest it, people say no, and then you never go back to it because you have all these other things you have to worry about. But that's where the EMRs can come in. If they can target, say, hey, this lady had gestational diabetes, her BMI is 40, she doesn't have diabetes yet, but she's a time bomb waiting to happen. Get her into one of these programs. If it just can alert you to doing that instead of her coming in for the headache and then dealing with the headache or the sore foot, just repeating those preventive medicine things. Because basically the patients are afraid you're going to bring it up. I'm going in there for my sore throat. They're going to weigh me and mention my weight. And then they leave. And so they don't want to mention their weight. So they leave. And when you don't mention it and they say, whew, I'm so glad I didn't mention that. But it's, I don't know. That's where the physicians can come to being a little bit more, trying to do more of that preventative stuff and referring stuff, I think.
If I may, what I'd like to try to do here is, I don't want this to get out of hand, but I do want to handle things in a logical manner. And so what I'd like to try to do for the panel today is I want to open this up to talk about 1, 2, and 3 all at the same time, because they're just different aspects of the same problem, which is to say, if I'm looking at the penny, on one side I see heads, the other side tails, and on the side I see the side of it. Let me try to couch this for the group. I put that 1-minute article that I just came across in my daily reading on physician primary care burnout. Now, the reason I'm mentioning this is because I guess what I'm trying to say from the physician's point of view is we're trying to give DMS a fair warning on this one. First of all, Kentucky is a beautiful state. I call it the Kauai of the East, but a lot of people don't want to live here. And I'll be candid with you, since I work on many of the workforce committees and on the board, our medical schools are not driving out a lot of primary care. We put out a lot of specialty care, and we train doctors for every other state in the country, because as soon as they get it, they leave here. And you all need to hear that, and you all should know that. And what I'm telling you here is you're having problems. Now, I think sometimes when you're not in the middle of it, you may have a different perception of what's going on here. I can tell you in my office, I get a sore throat a couple of times a week, because you know what they come in? They don't come in with that. We handle that by phone and telemedicine. They come in with diabetes, hypertension, dyslipidemia, their shoulders hurting, and they want to know what this is. And by the way, I want to add a couple of quality measures. Heck, I'll add 3 or 4 quality measures. The answer to that is no, and it's not going to happen. And if you all think it's going to happen, you're no offense here, but your neighbors are the Easter Bunny and Santa Claus. There's not enough time to do it. It's not going to happen. And primary care, as far as I'm concerned, this is the physician TAC, not the extender TAC. Let me tell you what, this is not about traffic copping. We're not here to send somebody to the orthopedic surgeon. I'm here to take care of that problem, and that should be done 90% of the time. Now I'm talking about, we're the guys not in charge of putting the cath in. We're in charge of making sure they don't go back to the cath lab, that their lipid studies are appropriate, that they're normotensive, that their protein in their urines are properly addressed. They're on the ACE inhibitors and the ARBs to protect the renal. That's what we do. And I think sometimes there's a disbelief or misunderstanding from DMS that we're like the cough and cold people, and that is absolutely not true. And so if you're going to ask us to shoulder this, you all need to understand you're going to have to, well, I'm not here to tell you how to pay for your services, but I think that you're seeing, and what this article brings to bear is the strain is beginning to crack. And when what they say, in the next 5 years, 20% of your workforce is just gone. And it's not coming back. And if you think about what's really happening, if you just step back for a second from the 30,000 foot point of view, we have telemedicine coming in from out of state providing care to us. Well, now that's why technology works. But now think about that, right? For every dollar you pay, how much is that coming back into Kentucky taxes or Kentucky reimbursement? I'll bet you 40 cents of every dollar that you pay out to a Kentucky provider somehow makes its way back into the economic cycle here. For every dollar you send out of state, well, they're not spending that money here. And what's happening is those people can't take care of your chronic disease care. It'd be fine if they could do that, but they can't. They can certainly take care of all your cough and cold and sprained ankles and UTIs and poison ivy, which is 20-25% of the health dollar. In Kentucky, we have people that are a lot sicker. And because of that, you're asking us to shoulder all the burden. And when you come back to number one and say, you know what, we're just going to write this regulation such that we're going to pay you a level 4 twice a year. And the rest of that time, we're just going to keep the money. Well, you can do that. But there's going to be a consequence to that, because all the people that I know never work for money when it comes to Medicaid. They work for service and for the glory of God. They work to help the patients in our Commonwealth. They do it as a service. But even then they're losing money. And this was just some type of capricious thing that somebody snuck in. And listen, I applaud you for getting it in there. But we've come to the point now where I'm just telling you guys, your workforce is breaking. And once it's broken, then you have really got a problem, because you'll probably never be able to fix it. I don't know how you're going to ever recruit people to come back into the Commonwealth and live here and raise their families here. And I'm telling you this so that you all can be able to say, you know what, if we're going to add quality measures, maybe we ought to pay for those quality measures. Maybe we should pay a certain stipend for primary care that's doing real primary care and not urgent clinic work. And maybe there's a certain fee for service part to that. I don't know. These people figured it out all around the country, but I would hope that you guys would know that. And all these things are related. This quality measures. Well, listen, I'm in an ACO and I can't tell you the amount of quality measures I have. I mean, I must have 20 quality measures I have to follow. And you can hear the frustration in my voice. And I guess we're trying to give ownership and a voice to all the thousands of doctors in Kentucky that are trying to do this work for you and are feeling they're becoming overwhelmed. And if we don't call this to your attention, well, what good are we going to do? And I guess the business end of it, and I'll be quiet here. If it gets too far and you have enough physicians leave and you don't have enough new doctors coming in, then your system will break. You will have people come in here, but they won't be the best doctors in the country. They'll be the people that, well, maybe nobody else really wanted that much, or people that don't want to come in at all. So, we're just going to do telemedicine and all that other stuff. You just send it to the ER. I mean, I'm just trying to say to you that I understand everybody has an interest here. I understand the MCOs are trying to make as much money as they can. I mean, that's just what they do. That's their entity. They're a capitalistic organization. They have stockholders. I understand DMS has a small cover. They're trying to pull it over everything and it can't get it covered. And the doctors are just trying to survive out there. But if we don't lay ownership to this and try to tell you the existential crisis that you're looking at in the next few years, we're not doing our job. And with that, I'll certainly open it up to anybody that wants to comment, and I'll try to keep as quiet as I can.
Dr. Thornberry, this is Charlie. I don't think what the commissioner was asking was that she was necessarily intending to put quality measures on the providers. She was wanting you all to help come up with stuff that DMS could be looking at with the MCO, as far as, like Dr. Terrio said, the obesity or cancer and stuff, that the items that we can look at, what reports can we get from the MCOs for us to see that that they are making improvements in our.
I appreciate that, and thank you very much. I guess we can provide those to you, but I mean, I think all the ACOs here have quality measures from DMS that they've already narrowed down on. And DMS might just start with asking a couple of the ACOs, so what are your quality measures that you all measure? And just kind of see how the medical directors look, how they feel about that. I mean, we can provide those for you, but that's work that was done 10 years ago, really.
This is Lee Geis with Policy and Operations and Medicaid.
Yes, ma'am.
And I would like to say I appreciate your comments, certainly. And the comments like that are what I believe the TAC is for. And those are the kinds of pieces of information, certainly your deepest frustrations, but we want to hear those, but what we would also like to hear is what can we do to help with that, because it's certainly not our wish to impose anything on providers that will further break the system. It is Medicaid is for provision of healthcare services to the most vulnerable and everyone else in the state. As the largest payer, single payer in the state, we are all about provision of services. But we also understand that we can't provide services if there are no providers. And so it's a partnership.
Well, Lee, I appreciate that. My general suggestion, and I don't do this for a living, I'm not a policy wonk, but my general suggestion would be is I think that what has happened not only in Kentucky, but in the country is you all compensate primary care like it's a specialty. You come with a broken arm, we're going to pay for the broken arm. You come in for a sore throat, we're going to pay for a sore throat. But primary care doesn't work like that. You see, primary care doesn't just fix your broken arm or sore throat. You all said it yourself already. We're supposed to get them to quit smoking. We're supposed to get them, even though when they don't want to do it, we're supposed to get that colonoscope and the obesity clinic. We're trying to solve a problem with people that don't have enough money. We're trying to get them on medications that are being denied. We're trying to get them tests. You see, there's so many other things that are occurring in primary care that are not compensated. And my general suggestion is that there probably, I'm not saying you should go out and buy a consultant, but there's a lot of work in this. There's probably volumes and volumes of work that are saying, well, if your primary care workforce is going to do the things that you all really want it to do, if you want us to lower these risk factors to socioeconomic problems, you should pay it differently, because it's not the same as going to see one of our specialists for, say, a GI problem when that's all they're going to talk about. And the GI guy's not going to worry about, other issues like their diabetes. We want to work with our specialty partners, but paying them is a different manner of paying primary care, because you're asking you to do a lot of things. And I would say DMS should probably investigate all the work that's been done and say, well, who else pays primary care differently and how successful are they? That's work that I might suggest that somebody in DMS knows something about it, because I'm sure you ought to go to meetings and they talk about this kind of thing.
You mean back when we did go to meetings?
Well, yeah, that was kind of a faux pas.
No. I was just trying to insert just a little tiny bit of levity into the conversation.
It's not real. This is not an easy problem to solve. And I'm going to tell you that if anybody solved it really well, I'm not aware of it, but there's more and more work to say. I'm not saying that primary care needs more money. I'm not saying that. What I'm trying to say is it just needs to be paid differently because it works differently, and you're asking it to do things. I mean, if you think about how many quality measures actually fall on the shoulders of specialists, well, hardly any. I mean, really. And then we have, like I said, in my MCO, we must have 30, that aside for all the work that you want me to do, on top of all of that, I have to make sure that all this other stuff is accomplished. And this other stuff is not small stuff, because it's what's actually saving the Commonwealth money. And so when we came to you a few years ago and said, we think telemedicine is a good idea. Well, again, it was allow us a way to try to say, well, we're going to have to work more efficiently. Well, I want to suggest to you that if you pay primary care like the way you pay specialists, you're probably going to get what you get. You're going to just get little small specialists. They're going to handle each problem as it comes in, and they're not going to worry about the quality measures because they don't have time to do it. They're not making a lot of money on these cases. They're businesses. They look at it like that. It's not that they want to give them any less. There's just only so much time they can give them. And so I think, again, if you all were sophisticated enough to go say, well, how are some of these larger states or more successful states with primary care? Who does that really well? Let's look at how they're doing it. That might give you guys some insight into how to work with us. And from there, we can try to open a dialogue to try to give you some insight. Dr. Neal, Dr. Thoreau, Dr. McIntyre, do you all have any thoughts here?
I got a lot of thoughts. If any of them want to speak, then I'm going to back you up, because we're in crisis mode as far as I'm concerned. Medicaid has gone from being the safety net to being the primary insurance for more than half of the people in this state. And I can tell you that, and I won't talk about reimbursement, but I'll talk about being able to keep doors open. I was a solo pediatrician for 45 years. And over the last 20 years, I could not have kept my doors open had it not been for KenPAC. Now, some people don't want to talk about pay for performance or monthly payment as an extra, but that's what kept our doors open. When we went to the MCOs, it was decided not to have KenPAC, and I brought this up before, or a monthly payment. at least one of the MCOs, and I'll say WellCare, actually kept that in force for a number of us who had large Medicaid practices, because it's the only way that we could make it. We could not make it with the Medicaid payments, and that gets into the limits on complex care, et cetera. But that kept a lot of us open. We're to the point now where most of the private pediatric, and I'll only speak to pediatrics, but Bill, I think it's worse in the family practice. Most of the private groups have capitulated and joined hospital groups or larger corporate groups because they absolutely could not make it. And one of the major problems there was the electronic medical record. There was no way that I could have afforded electronic medical record under those circumstances because of software issues, the problems with that come along. The other thing that came up there is that I couldn't become a patient-centered medical home because I did not have an electronic medical record. So those are just a few of the things that chipped away. And I can tell you now that it's felt that fee-for-service is outmoded, and now we need to go with ways of payment for quality care, which implies that we weren't giving quality care, and the only way we keep the doors open was to see more patients, and that was actually true. We're in the situation now where a good pediatrician on a good day can probably only see somewhere between high 20s and low 30s of patients a day. And with reimbursement as it is now, there's no way that they can keep the doors open. So what it looks like to me is that the larger systems that employ pediatric groups are making up that loss by income from Medicare patients, that sort of thing. So I'll stop there and see if somebody else wants to jump in.
Anybody, please.
Yeah, this is Dr. McIntyre. Just a couple of thoughts. One of them is that, as Dr. Thornberry was saying, doctors can go elsewhere to do better. Kentucky borders 7 other states, so for a large proportion of the physician population, they don't even have to move to practice in another state. For example, in Jenkins, where I live, I'm 2 miles from the Virginia state line and can practice in Virginia almost as easily as I can practice in Kentucky. On telemedicine, that's one of the few good things that have come out of the COVID crisis, is that telemedicine has become accepted and is being used on a widespread basis. But I keep reading about things, proposals to restrict telemedicine payments as we come out of this crisis, which I think would be a bad thing.
Dr. Thoreau, do you have anything? Judy?
I mean, I agree with actually what everyone has said, and then what I'm thinking, what's going through my head is more of a value-based payment, which type of opportunity. I know some of the MCOs have started some of that this year, but it's not very widespread. I also agree that limiting the level 4s and 5 office visits needs to change because it is true that if you have a couple of chronic illnesses, which most adults have, then you're doing a level 4 and 5 all the time, every time they come in. So I mean, that will be one way to change or improve the payment for what you guys are doing in the office. But yeah, I think it's a big problem. I mean, it resonates with me. I have maybe a few days in my life reached 30 patients a day. And I pride myself on being fast, but that's about it. Most of the time I'm around 25 and then you go home and you do your notes. So you're not really finished after the 11 hours, but, and I truly am one of the fast ones, but I mean, so I hear what you guys are saying, And I do think it's going to get worse. I also think that even in our pediatric residency program, where we are primary care, most of our graduates are going into a subspecialty at U of L. So they're going into the NICU or an ER or pulmonary or GI. They're not going into primary care pediatrics. And I think there's a lot of reasons for that, because I'm not sure they actually realize the payment options or at the time that they're finishing their residency. But they know primary care works really hard, and they see other things out there, and they have a huge amount of student loans, and I think that when they're logical about it, see how they can pay off those student loans, working primary care pediatrician. So we do have a lot of problems.
Well, I think that this kind of all moves back to our first principles of say, Barbara Starfield, speaking of pediatricians. Dr. Starfield's work several decades ago basically stated on every level, whether it was a city or town, a state, or a county, commonwealth, or even a nation-based level, systems that have good primary care have better outcomes and lower costs every single time. It has never been disproven, ever. And I think what we're trying to do is, I don't want our voice today to come across as chiding anyone. We are all equal partners. But the thing of it is I mean, for example, if I have the head of the MCO, well, I mean, I can't really come and do business in Kentucky or make money unless I got somebody out there that's willing to do that work. And the people that are doing the heavy work are your primary care workforce. But yet the medical schools are not driving primary care people. Again, we're training people, they're just leaving. And they're not coming in primary care, they're coming in neurology or pediatric, they're just going in a different area. And so why would we have to give them a reason to stay? Now, the reason is not just money. But on the other hand, how do you ask them to say, well, for example, I'm sure a lot of people on the call have never worked with an EMR. Well, the EMR might cost you $60,000 or $100,000. Well, they might as well give it to you for free, because it's $2,000, $3,000, $4,000 a month that they get you on. And if you don't keep it up, you know what? When it breaks or there's an update, well, all those records that you had in there are worthless. So it's not just annuity; it's an annuity that they have you by the short hairs. They can anytime decide what they want to do, and you're going to have to play ball their way. And it's not just that. Now they have telemedicine systems that work just the same way. I have all my patients on a telemedicine system. Well, now I get mad at that company, I go to another company. Now I've got to get my patients to all go into another company. You see how, and at the same time they come in and you say, well, Kentucky has 35%, COVID vaccination. Well, who's the person that's really going to get that accomplished? Do you think some ad's going to do it? Well, it might get their attention, but that happens on a one-on-one granular basis. Every time they have an interaction with the health system, we have to be there to counsel them, but that takes time. Neither I'm going to take care of their diabetes or I'm going to take care of the COVID. There's only so many hours. I think Judy kind of said this, and Dr. Neal has pointed out to it. There's only so many minutes in the day that we can accomplish these things. And so if you've asked us to on these quality measures, saying, well, we want these quality measures, by dollar, we do too. The quality measures really started with us. But we don't have the time to do it, because when we do make the time to do it, there's just not enough compensation to keep your doors open. If I take care of this, I kind of tell some person I can't see them today. And what we're saying is, if you are using a more sophisticated way for primary care, you're saying, well, we want you to fix the broken arm. We want you to do their diabetes and their high blood pressure and cholesterol all in one visit. Okay, but can you spend some time on smoking cessation with them? It might not work the third or fourth time, but the fifth time, they might bite on it. And a lot of my patients do. Or would they maybe go to the diabetes counseling about how to prepare their foods and shop properly? Well, again, if you pay for that, I think we're going to get better outcomes moving forward. And we hope that you'll be able to see that. And again, that's why I've brought all these together. The limits on E&M. Well, there's sometimes, again, I don't want to monopolize the conversation, but I have diabetics. I have a lot of them in Kentucky. They come in, and every time they come in for that visit, we're talking about their blood pressure because they have hypertension. We're talking about their diabetes. And if amendments have to be made, we're talking about their lipids. And that's the minimum, because a lot of these people have either vascular disease, smoking, or something on top of that. And then, of course, I'm trying to adjudicate some other quality measure. Or they say, well, listen, I have this other problem and I can't get down here next week. I can't reschedule. I don't have a way down here. Would you take care of this too? And you know, and that's for free, right? I mean, once we're at two problems, that's a 4. So anything we do on top of that is for free. And you know what? We do it anyway, because that's what we're here to do. But we want you all to understand what's going on, because if we don't tell you this, you know, you have no idea of how this is working, so that you can't solve these problems for us. And we're hoping that you can work with our MCO partners and say, you know, in Kentucky, we have a lot of sick people. We have a lot of chronic disease. If we're going to ask them to do this for us, if we're going to try to come in and make a profit, we need people that are going to do something about that. And there is no better, well, that's not true. I think prescription generic drugs are actually give you a better return on investment than primary care. But in the healthcare system, it's number 2. Primary care, good primary care, is the number 2 cost savings measure in the entire health system. And I hope that you'll consider investing in that. Help me, somebody.
One of the things I'd like to ask you is, you're talking about, and as Dr. Terrio was talking about, the 99214s and 215s. Is there some other criteria that we could place on, like maybe a diagnosis code, that we could place on having every office visit be 215 or a 214? I mean,
Well, Lee, it's a great question. And the short answer is, it kind of came up last time, is kind of no. We are responsible by law and by ethical obligation to say, candidly, this is what we've done for you all, and we need to code it properly. And when we do that, it comes out the way it comes out. Now, almost in primary care, with the kind of care we have in Kentucky, I'm not going to talk about urgent care for cough and cold stuff and poison ivy, but real primary care, which is what we're dealing with, almost always they come in. It's very uncommon somebody walks out of my office with a 4, because if they do, they probably don't need to be there, or I handle it by phone. I just give it to them. And so there's no such thing as what's a CPT code for that? Well, there's no CPT code for that. We just have to tell you what we've done. And that's why a lot of people, and I think Dr. Neal suggested, you know, when these people that are providing primary care, real primary care for you, if you can identify those, you should say, well, maybe we should see a system of who's worked this out over the last couple of decades on, is there an extra stipend for those people for taking care of our patients? And you know what, we're just not going to give you the money tag on it. We're going to make sure that certain quality measures are intact. And that's where Judy would come in. And I would expect Angie would say, well, we want these quality measures. If we're going to give you this extra money, we want these quality measures addressed. And that's a good quid pro quo. That's what we want to do. We want to show you that we're doing these quality measures. But on the other hand, in order to be able to do that, we have to make the time to do it. That's how I would solve the problem. But now there's smarter people than I am, and people that do make their living doing this. And they've done it for decades. I just don't know how they do it.
Bill, very soon we're going to have a serious discussion of this 992131415. They had talked about blending it, and you remember actually a year and a half or so ago, it was supposed to take effect. Well, we spoke against that, or it decided that that wasn't what should be done. But we're going to have to do that, because we're right now, if you look at the studies, somewhere between 40 and 60% of every pediatric visit properly coded would be a 99214. And it's way below that, because most of us older pediatricians didn't code it above because we didn't get paid if it was more than 2. So I think DMS has to look at that very quickly. And with a discussion of how we change that. The other problem with value-based care, the way I've read everything I can find on value-based care, and it involves pediatricians and family practice doctors assuming risk. And the MCOs, that's what they do, is calculate risk into their premiums and all that. We can't calculate risk into what we charge. And I think that's something that needs to be thought about more. We don't have time to even think about risk. The risk to us is providing good care to our patients. And I think that DMS, somebody needs to call some of us to discuss it somewhere along the way. So I'll stop there.
I thought that's what we were doing, is discussing it.
Well, we are now. Yes. Is that Lee? Is that
Yes, sir.
Yes, Lee. I've known you for years, and you all have always been very fair with us, but we're still strapped by what the people above us have said we can do. And so I think that we need to have have discussion. The Medicaid Advisory Council, which I served on for a long time, needs to discuss that because there are a lot of stakeholders involved, home health, optometry, pharmacy. Everybody is kind of tied to the physician because that's where all these services start. And so we've got to look at all of that, and we've got to do it pretty quickly because, as Bill says, we're approaching the edge of the cliff pretty quickly, in my opinion. Hello.
It used to be that, they changed the coding guidelines January 1st, 2021. So before that, the vast majority of the at least in pediatric offices, the codes that people coded were the 99213s. And now they've switched it to better show what people are doing, the time and effort that you're putting into the visit. So now probably 60% would be or more might be a 99214. And so I think that does have to change because if you're coding properly, you're going to be coding for a 99214, and then it's not going to be reimbursed after the second one.
Well, Judy, I think you're right. And I think, again, I want this to be a very positive discussion. I think what as physicians we're trying to do is, I think we're trying to bring to your attention that there is an imminently impending crisis. And I think that at that point, we have to leave it with the department to decide how you and the administration think it's the wisest way to manage this and to work with the commissioner on that. I think what are some of the things that we suggest is, is it time to get together a group of people and sit down and begin to have conversations about maybe in Kentucky, do we need to, like in Kentucky, in 2018, 17, we saw a new vision for healthcare delivery here. And a lot of people in the country shared that. Well, should we look at a new vision of the way we're going to have to work with our primary care providers, at least in our state, to make this work? And is it time for that? Well, only you all can decide that because you're the referee here. The MCOs, God love them, are going to do whatever. They're like children, man. I mean, they're going to do whatever they can get away with. If they can get away with saying we're going to pay for 299,214s a year, well, they're going to do it. But at this point, does it serve your interest? Does it really serve the Commonwealth's interest if all of a sudden the infrastructure implodes? Well, I don't know, but you all got to decide that. All we can try to do is try to say, we'll be partners with you. We're calling your attention to this. And if we can help you, we will. But again, this is not our expertise. There are companies, I'm sure, in very large states that have worked with this for many years. And I don't know what their outcomes are because I don't do that for a living. But you might want to consider it's time to decide either internally that we need to have in the next few years, we got to solve this problem because it's not going to go away. And if you do think that, maybe you could have other roundtables. I don't think this small committee, which is a subset of a larger committee, I don't think that, committing it to death is going to solve that problem. But I think we were trying to tell you in a very direct way, there's a major problem here. It is not getting better, and it is getting worse. And I really don't know. When I saw that article, and that article is the tip of the iceberg, it's worse in Kentucky. I can tell you because I'm on these workforce committees, it really is worse. I don't know how long it's going to go until it does break. When it does, it'll be a problem. I guess it's just like an iceberg. It sits there and sits there and sits there, and finally it snaps. And when it goes, it'll be too late to fix it because it'll take several years, in my opinion, for this to be corrected. Judy, do you have any last thoughts? I saw you trying to chime in there for a second.
No, I do think COVID has made things worse and made the burnout worse, and people are just tired. And it might be the straw that breaks the camel's back, and you see people leaving the workforce even sooner because they just can't keep up the pace. It's just too hard.
Well, I think we beat this horse enough, and I appreciate the gentle ears of everyone here. And again, I'm sorry I'm so passionate about this. I guess when you live this for 20 years, or with respect to Dr. Neal and Dr. McIntyre, maybe a bit longer, I love this state. I love my Commonwealth. I want to see great things for it. I don't want to see bad things for us. And I hope that we can do it a better way. And I hope that we have great leaders in our positions with the with not only DMS, but also our MCO partners that can help us solve these problems so that everybody can win and nobody gets the short end of the stick. Because if we don't have anything if it finally does break, it'll just become catastrophic. I mean, businesses won't want to move in here. People won't want to stay. It'll just become a welfare state. But if I could, I want to close that down and just, Ashima wanted to work on a topic for contact lenses. That will be our last topic today. Ashima, can you help us out with that? We can move forward, please.
Sure. We recently had a board meeting, the Kentucky Academy of Eye Physicians and Surgeons, Monday night, and it was brought up that Medicaid covers specialty contact lenses through the age of 20 or 21, I believe, and then of course after that age they're treated as an adult and contact lenses are no longer covered. So this is just specifically specialty contact lenses for specific eye conditions like keratoconus, corneal deformities, where patients can actually improve their vision with a specialty contact lens, and they can avoid surgery. So what happens is that after the age of 21, these contact lenses are no longer covered, but of course the surgery is covered. And so they don't have the money to pay for these contact lenses, which can be several $100s, but instead a much more expensive surgery will be covered. And of course, there can always be complications from that surgery. So that actually costs the healthcare system more money by having these patients choose surgery over something that could clearly be taken care of with a contact lens. So that's just one example. There are several other eye conditions that also can be taken care of with specialty contact lenses. So I know it's a long road, but I wanted to bring it up. I'd like it to be brought up. I mean, I would love to make a recommendation that Medicaid cover specialty contact lenses for specific reasons throughout a patient's lifetime, rather than cutting it off at the age of 21. And I'm sure the optometry TAC would be very much for this as well, because they see a lot of these patients requiring contact lenses. So that's what I want to bring up.
Would anybody like to discuss Dr. Gupta's point?
I'd like to second her recommendation. This is Dr. McIntyre.
Thank you, Dr. McIntyre. So we have a motion there. Would anybody, before we vote on it, would anybody like to discuss this from any of our partners in the MCO or for DMS? Okay, there's been a motion brought to the floor. All those in favor, say aye.
Aye.
Aye, Don Neal.
Yeah, any opposed? No opposition. The motion carries. We'll forward that to the MAC.
Dr. Gupta, and excuse me for interrupting, but Dr. Gupta, would you mind very much to forward some of your research on the specialty contact lenses? That would certainly, since apparently you've already done some, or there is some out there, if you could send that to us, that would help us. We're doing a review of our adult vision benefits now. So that would be very helpful to us, and I would certainly appreciate it.
Okay. Should I send that to?
You can send it to Charlie and she'll get it to me. Yeah.
Okay.
Thank you.
Thank you, Lee. Is there any more business before the committee today?
I'd just like to request McIntyre again.
Yes, sir.
Dr. Gupta, that for the MAC meeting, that she present this rather than me, because she can answer questions and is much more knowledgeable about this as a pediatric ophthalmologist, certainly than I am as an ER doctor.
I'd be happy to.
Oh, thank you.
Bill, when is the next MAC meeting?
Thursday.
Thursday? Okay, all right.
10 a.m.
Dr. Thornberry, since you do have a quorum, can you approve minutes from your last meeting? You're on mute, sir.
Charlie, I'm so sorry. It must
You're
have
fine.
slipped my mind. Are there
That's
any
okay.
additions or deletions to the minutes from the last meeting? If there are none, can we accept them by acclamation? All in favor?
Aye.
Aye.
We'll file the minutes. Thank you. Our
Thank you,
next,
sir.
thank you, Charlie. I'm a bad boy.
No, you're not. You're fine.
Our next meeting is scheduled for November 12th. However, if there's not a substantial calendar, I'm not going to bring our group back unless we have some real work to do. If we do, of course, we'll let everybody know. And again, thank you for your morning. I really appreciate it. Enjoy your weekend, everybody.
Thank
Can I
you.
just,
This meeting's adjourned.
Bill had something he wanted to say.
Yes, go ahead.
yeah, we had planned to have a in-person meeting in November. Do we want to move that
Well,
plan forward to March?
it's so far ahead considering the amount of COVID and the way these new variants are acting. I think that it might be best to work with DMS and the governor on that when we get closer. I mean, we would always want to be in person. I think that's not a bad thing at all, a few times a year. But I think at this point, I really can't see that far ahead. Would the committee like to meet in person if we could in November? Would that be good? Would everybody be agreeable to that? We would be, I guess, in Frankfurt, wouldn't we?
I
I would
would.
prefer not to, given the increasing rates of COVID.
What was that, Ashima? I couldn't hear you.
Oh, I said I would prefer not to, given the increasing rates of COVID right now.
Okay. Well, let's see where we are. Again, this is we're in the middle of September here. It's just a long way away considering the way the virus is acting. So when we get closer, I think we'll have a clearer picture. Okay. But we'll keep everybody informed.
Right. Bill Donnell, quickly, did we have any of the MCOs in attendance today? I couldn't see. I saw Tom James was on, but I'm not sure exactly. Nobody spoke up.
Dr. Cantor's in. I see her.
Okay, all right. Because it's very important to have their input into this, and that's why I like the in-person meeting, so I know who's there. But also, I think that they're so important to us at this point. We need to know that. Okay.
Actually, Dan Bruner and Peter Thurman are here from Anthem as well.
Thank you guys for coming.
Yes, thank you.
Dr. Bruner, I see you here too. I didn't see that on my screen. I see you too as well. I'm so sorry.
That's okay.
Thank you very much.
If you click on the participants button on your computer screen, it'll show you all of everybody that's in the meeting, so you can see if you know who know who the person is you're looking for. You will see them.
Well, that's the problem. Only one of them, well, two say who they're with. Otherwise, it's just listed by name, and sometimes we don't.
Oh, yeah. Lisa Galloway and Kathy Stevens are here from Humana too.
Oh, hi, Lisa. How are you?
I'm good.
Thank you for coming. Well, do we have anything else to do, guys?
No, thank you, Bill. You did a great job.
Okay, well, thank you, guys. Judy, it's great to see you as always. Thank you, Charlie, for helping us.
No problem.
Bye-bye.
Thanks.
Bye-bye.
See you. Yep. Have a good day. Bye-bye.
So it lasted just